Hi, Jonathan.
Hi, Emma. Hey, it's
Cut to
Cut
the
to the
case.
Case. And don't tell me you've got a case.
I do have a case. I have an interesting case from just the other day.
Mhm.
So I saw a 60-year-old man who had an angle grinder injury. Guess where it went?
Well, either the forearm or kick back to the neck.
Kick back to the neck.
Kick back to the
Yeah.
neck. How did I know?
So lovely man who was getting some rust off underneath the car and had an angle grinder injury to the neck with significant bleeding and hypotension. So that was our pre-hospital notification.
Can I just say one of the two tools that should be banned? So ladders in older people,
Yes.
angle grinders. Anyone. I'm not allowed to have
Yeah.
one. Okay.
Stick with the secateurs.
So older guy, angle grinder to neck, and hypotensive.
Yeah.
Yeah.
So why don't we break it down to how do you prepare? So we got 10 minutes warning that this patient is coming. They were hypotensive. I think their blood pressure was 80, and there were reports of significant blood loss at the scene. So for our hospital, and every hospital is different, that's a trauma call because there's physiological derangement. And why is it a trauma call, Jonathan?
Well, I mean, the thing about, it's actually quite scary when you think about it. Most of the patients we see with neck trauma and neck bleeding are all right. The other ones don't actually make it to hospital. So to get someone who's got blood pressure of 80 is quite different to normal because they just bleed out so quickly. This is a trauma call because this guy's going to bleed out or has bled out very quickly, and he has to go to the operating theatre.
Yeah,
so this is shock trauma, low blood pressure, blood loss. Got to stop the bleeding. It's actually pretty straightforward, but not that common. But we do prepare for this, and we see a lot of this.
So we prepared our trauma call response. So we've got our trauma team, we've got our ED team, we've got our specialist nurses, we've got the anaesthetist, and so what we do is our
blood clinician and the blood
clinician. We've got blood ready. So really we're worried about a penetrating neck injury or a significant neck injury that's bleeding. So we're worried about C, but let's face it, it's here. So we're also worried about A. So talking to my team, they were the concerns I expressed to them. So, with your role allocation, everyone is confident in their roles.
You briefed your team.
Briefed your team. And really it was about preparing for the bleeding. So compressing the area and giving transfusion, but also anticipating that there might be a significant airway injury. And certainly I've seen plenty of those. And so the approach to the airway injury. So is that patient going to need to be intubated from the top end? Is there going to need to be a front of neck access? So we were prepared for both eventualities.
Yeah, got it.
Anyway,
personally, I would have highlighted just one thing, and the thing that I like to highlight is the catastrophic hemorrhage part.
Okay.
So it is stopping bleeding and giving the blood.
I think I've been involved in quite a number of
seems like these one of your subspecialty areas, Dr. West.
And I've had difficult airways. So as I'm thinking worst first, and I wanted it to go smoothly if indeed he had an airway injury.
Got it. Yep.
Anyway,
what happens?
He arrived and he was actually hemodynamically stable, fortunately. So, but you don't know that. So he arrives and you've got that exchange of information that needs to come across. So the team were briefed to perform that primary survey while we received ambulance handover from our mobile intensive care paramedic. So they said,
just let me interrupt. Did he arrive with someone putting pressure on the neck?
Someone was on the neck.
Yeah.
Why
do I say that?
Yeah, because it's a good thing to stop bleeding.
Because it means that he's not actually stable. He's only stable because someone's putting pressure on the bleeding.
I gotcha.
It's not like the bleeding's over. It's over and done with. Let's relax. This is actually what I'm thinking. If I'm hearing you right, we've only got
with pressure. Everything's okay.
That's right.
Okay.
Yes.
Well. So fortunately, I was able to hear from the paramedics. They were, they had reasonable IV access. They've made an assessment of the airway and weren't concerned, but they said there's a significant wound on that left-hand side of the neck. So in and around our assessment, we've done the ABCs, and actually we were able to talk to this man. Now, what does that tell you about the airway assessment if you're able to talk to the man?
That's a good sign. I mean, the stuff you get early on. Is he able to talk to me? Sounds really simple, but it means he's awake. Means his airway's probably okay, and he's probably doesn't have respiratory distress if he can actually just talk to you.
He could, and he's perfusing his brain.
So automatically, big ABCs have been ruled out, and obviously, if he can't talk to you, he's kind of loss of blood, unconscious because he's bled so much. So I'm reassured now that he's talking. But how was his voice?
His voice was normal.
And
So-
why do I say that?
So he's not got a hoarse voice. He's
Yeah.
not coughing up blood. So he's not got any external evidence by, just assessing his speech that he's got a penetrating into the larynx injury. So he's not coughing up blood. He's not got a hoarse voice. He was swallowing normally, and he actually appeared relatively calm, except it was hard to get to him because he had someone having
So he
pressure on
probably
his neck.
hasn't got any of those hard signs of airway injury.
What are you talking about there,
Yeah,
Jonathan?
well, this is the thing, right? I think people get themselves tied up in knots about hard signs of
a neck
airway,
injury?
neck
Yeah,
injury,
yeah.
airway injury, and vascular injury.
Yeah.
I think they're important to look for, but people get caught up in lists. Is it this, is it that? And it kind of throws them off. Likewise, the zones of the neck, but maybe we'll get to that in a sec.
Yeah, we'll get to that in a second.
But, it's common sense. Airway, is he talking? Is the voice hoarse? Are things swelling up? Is there bubbling? Breathing, is he breathing? Has he got equal air entry? What's his oxygen saturation? Things like that are going to be
His
important. to
primary
me.
survey was normal,
Primary
including
survey.
a EFAS to the neck and a chest X-ray.
And the
Everything's normal.
circulation, obviously, not normal because the bleeding is they've only got a circulation, but they've got pressure on there.
Numbers are good. Heart rate's 100.
So don't
Blood
forget.
pressure is about 125 on 70.
What I'm saying is, don't get hung up on the list of hard signs for the primary survey of neck. Just do your normal primary survey and think about what the likely injuries are, and just focus on what
Yeah,
there should be.
but do a thorough assessment.
Do a
Break
thorough
it down into
assessment.
what you need to know.
Look, listen, and feel, right?
All right,
So,
I've got a
yeah.
question for you.
Yeah.
So how do you want to prepare to look at the neck given someone's compressing the neck? What do you need?
Well, you can't put a tourniquet on,
No,
and release
if
it.
someone's doing this before
Yeah.
they pull it off, what are you
Yeah.
what
So-
are you going to instruct your team?
I would have just checked with them. Well, what was it doing before you put the pressure on? Was it actually squirting out like an artery, or was it just hosing?
So he
Was
had
it-
pressure on it,
Yeah.
they put more pressure on it,
Mm.
and they were putting quick clot on it.
Oh yeah.
And they think they have stopped the bleeding.
Okay.
But what
Yeah.
we did is we made sure we've got really good IV access. So two
So-
large bore peripheral cannula. Make
Because,
sure you've got pain relief.
because
I'm
when
going
you
to talk over the
release,
top of you. We also made sure that we had blood available.
what a surprise you're talking over the top of me. Look, you're gonna this is what's gonna happen. You're gonna release this thing. They think it's stopped
Yeah.
bleeding, and then you're worried that it's just gonna bleed out on you. So what I think you're saying is you're gonna prepare for that at every
That
eventuality.
eventuality. That's right.
IV access, blood ready, blood clinician, some sort of compressive gauze or quick
Yeah.
clot on there to stop bleeding.
One more thing as well. I've got someone who is the ultimate decision maker and has
Mhm.
the door key to theatre.
Yeah.
So I have the surgeon with me, and that's really important because
They
what
were
I
there-
don't
they
want
were
is
there,
to have a
yeah.
look and see all the bleeding happen and he become hypotensive and then have no next step.
Yep.
Really, his next steps are either to CT because he's stable and we don't need to compress the neck, or he's going to theatre, one or the other. So
So maybe don't
got the
act-
surgeon, got everyone ready?
don't take the wound down until don't take the dressing down until you got the right person there.
Yeah,
Yeah.
that's what
yeah.
we did.
yeah.
Pulled down that dressing
Mm.
and oh my goodness, there
Mm.
was an extensive left-hand sided neck injury. It was essentially the whole neck and an angle grinder. And you can imagine what I saw. So
hold on,
platysma or no
Yeah,
platysma?
yeah. So and zone?
Well, so what are the zones of the neck, Jonathan?
Well, I'm glad you asked because I'm going to bump that straight back to you. There are 3 zones in the neck. And they start backwards, don't
Yeah,
they?
they
So
do.
zone
Yeah.
1 is
Yes.
what? Cricoid, so sternal notch to cricoid,
Yeah.
and then cricoid to angle of mandible,
Yeah,
and
and
then
above.
zone 3
Yeah.
above.
And it's sort of an investigative modality that can direct what you do next.
Because I think back in the old days, like the old days, before we had CT angio so easily available, the investigations were dictated by which zone
Yeah.
the injury was.
And practically now,
That's not so relevant. So
everyone gets a
practically
CT neck,
now,
don't they?
if
If they're
the
stable.
if the wound is through the platysma, i.e., through the the tissue that you see through the fascia, then potentially any of those structures are injured, and you'll need a CTA to work out whether the vessels are injured. So if it's through the platysma, you're going for a CTA. So the zones aren't so relevant anymore.
Yep,
Um,
good. So guess
This
what?
is through the platysma.
Blind Freddie
So-
could have seen this as through
Yeah,
the
right.
platysma. It's
Okay.
a really big, open,
Yeah.
gaping wound.
Right. Well, that's
Now,
just- yeah.
interestingly, there was no bleeding. So it really extended from almost midline and quite lateral.
Yeah.
So it's just a messy, what do you call it? Piece of shared equipment. What's that called?
Okay, I don't know. What do you say?
Tool.
Tool.
It's a messy tool that's gone crazy on the
It's
neck.
holding it sideways.
Yeah.
It's grinding sideways.
Yes.
So when it kicks back, it's going to
Yeah.
hit you sideways
Yes.
and cut straight across.
So he's stable, early decision making. We're going to prioritize the CT scan.
Yeah.
We checked he could lay flat and he was really comfortable, got some good analgesia, didn't need compression, went off to the CT
Okay,
scanner.
so the fingers come off
Yeah, he's fine.
and he's not bleeding.
Not bleeding.
Yeah, and the
Gave
wounds-
him
yeah.
enough time to know that
All right,
this
that's-
is right.
yeah.
Got all the resuscitative care there, all the equipment that we need, and he was prioritised for CT. Off to CT?
Sounds like end of story, Emma.
No.
Well, it would have been end of story for me. I'm happy.
So
yeah.
on CT, he starts to bleed.
Mhm.
Yeah. Which is probably timely because it allows you to see what's bleeding because you're doing a CT angiogram.
Yeah.
But most importantly for the patient,
Not ideal.
the
not-
nurses provided amazing care. So they said, he's bleeding, I'm worried. And so we came back and assessed and went, oh, he's bleeding,
So
it's probably
did you
venous.
Did you finish the CT?
Yeah, finished the
So you
CT.
just
No,
yeah.
no, he was finished the CT. So
Yeah. Yeah.
when everybody leaves the room for the 15 seconds, he
Yes.
started bleeding.
Yeah. Because really, sometimes you have to make the decision. Do I continue on?
Yeah,
or
we
just
didn't have to
explain
make
off?
that decision.
Yeah.
He was safe. He wasn't bleeding when the 15 seconds started. And by the end of the 15 seconds, he was bleeding.
He wasn't exactly.
Yeah.
But
Yeah.
see that information from the CT
Yes.
is really useful.
Yeah. Now,
Yeah.
he did have a dressing on, and that actually probably created some difficulty because there was some bleeding. Initially, we made the assumption that this is just venous bleeding, like there's a horrendous wound there.
Yep.
But it soon, over the next 15 minutes, became clear he was pooling bright red blood,
Okay,
and he was
yeah.
bleeding through the dressing.
Right.
And it quickly became apparent that this is arterial bleeding,
So little artery.
probably a little artery,
Wasn't
not the
squirting all
carotid.
over the room.
No,
But it
yeah.
was
Yes.
brisk.
Yeah,
Yeah,
risk
okay,
bleeding,
all right,
risk
well, that's-
bleeding, running down the back, running down the
Yeah,
front,
like-
running through the.
Like the ambulance would have found.
That's right.
Yeah.
Yeah.
Okay.
Yeah.
Well, that's
So
a big problem.
what
Yeah.
what would I do? What would you do?
We're going to theatre.
Yes, I would like
Let's
that.
go to
But
theatre.
what else do you do just prior to say going to theatre?
Well, look, I reassess again.
Yes, I put pressure
We're
on it.
still in
Let
catastrophic.
me help you out.
We're still in catastrophic hemorrhage
Yeah.
land. So pressure on.
Yes.
Check my access is adequate. Upgrade my access if it isn't, and
Yeah.
start giving blood. I mean, we check his vital signs. What's his heart rate? What's his blood pressure?
Initially, okay.
Yeah.
I started putting pressure on the wound. And then I was able to, with my other hand and with my colleagues, make some phone calls to advocate for him to get to theatre.
You've got the one hand.
Yeah,
on the
one
thing,
hand on the
hand
patient,
phone.
one hand. Now,
Yep.
that
Yep.
made me stuck in the room, which was actually good.
Mhm.
It really made me very urgent in terms of my need to get him to theatre.
Well, your focus needs to be on that patient. He's
Yeah,
the
and it
sickest-
was.
He's the
It
sickest
was.
patient in the department.
Yeah. And over a short period of time, he became agitated.
Yeah.
I think partly because the pressure was extremely uncomfortable and he needed pressure to stop the bleeding. And at the same time, he's getting nausea and he vomited and then he's hypotensive.
And
So
he's looking unwell.
yeah, all
like
that stuff.
he's
Wanted to get off the
shocked.
bed. Any
And
patient that wants to get off the
yeah.
bed, it's a bad sign.
especially when you're pushing them down.
Yeah.
Yeah.
Now, this is where the tricky part came in because he'd had a really fantastic assessment by our surgeons, but it was sort of change of shift. So it's a new
Yeah.
team coming in
Got it.
and
Yeah.
they said, well, he's stable.
Yeah.
And
Well,
so it was,
even dare I say, hand it over as stable because
Yeah.
your team's changed.
that's right.
Yeah, that guy in trauma one, he's okay. CT looks
Yeah.
pretty stable.
Yeah.
Right.
And so then it was really about employing the techniques of respectful communication, but greater assertiveness.
Yeah.
So I had a man that very clearly had to put pressure on to stop the significant bleeding in
Yeah.
his neck and he's hypotensive and agitated. But it was about being able to communicate with staff that he needed to go to theatre. So the issues that I faced were initially, I didn't realise how the seniority of the person I was communicating with and, you know, they were actually junior.
Yeah.
So it really required some thinking and probing about what was happening next. So I said the words, he's bleeding, it's an arterial bleed, he's hypotensive, I'm resuscitating him, we need to get to theatre.
How'd that go down?
Great, from my end, it just
Yeah.
didn't result in
Yeah.
anything. So
What do you
it was,
reckon- What do you reckon the reticence?
no, it wasn't reticence, it was just,
Well, why you're talking to a junior person?
yeah.
Why is it the junior person can't just go to theatre on the basis of what you
Well,
said?
they're not the decision maker
They're
to
not,
go to
no.
theatre. Yeah.
Yeah.
So with a bit of time, you know, I'm sort of 5 minutes, I'm thinking this isn't happening. Now, why isn't this happening? They're probably junior.
Mm.
So it was through thinking about it and then taking the next step.
Mm.
So does your boss know, are they coming? Are we going to theatre within a time frame that is short, i.e. 5 to 10 minutes?
Yeah.
So that really got me going. That really got the team moving.
Yeah.
But while I'm there, I did some other calls. I called anesthetics, and then
Still with a hand on the neck.
still with hand on the neck,
All the,
and my
speak
phrases
up.
became shorter.
Yeah,
So,
yeah.
if you've got sort of 10 seconds or less to communicate to the anaesthetist what's going on, what would you say?
Got a carotid injury, penetrating carotid injury, a shocked patient who needs to go to theatre. We need an op stat. I'm putting pressure on the wound, and that's the only way I can stop the bleeding.
Perfect.
I need a surgeon to operate. Have you got an operating theatre for me? I'm going to get you a surgeon to do it.
Yeah. That's along the lines of what I said.
Yeah.
It was sort of that less is more. No, and really it's not. It's about, I've got a shocked patient with a penetrating neck injury with arterial bleeding. They need theatre now. So it's very tight. It's very clear what you need.
Yeah.
And so that was also that direct communication, that style of direct communication is also really good. So it's really worthwhile sort of rehearsing the phrases that you might say.
I think so. I think that's key, isn't it?
Sort of what you would say when.
What you say when, how you get it across.
Yeah.
And then, but dealing again with this junior person.
Yep. They did a great job, by the way. They just were.
Yeah.
Boss is not here.
Yes,
I don't know who to talk to. I don't know what happens next.
So it sounds like they.
So really, they just required extra support to be able to.
Yeah.
Push it forward for that patient to get to theatre.
All right. And the boss came down, or you went to theatre, or what was the?
Yep, team came down, went to theatre. Didn't explore it in the room, obviously, which I was pleased to hear. They'd seen the CT and there was an arterial blush, and in the end they were bleeding from a superior thyroid artery. But they couldn't. You couldn't repair that in ED, and not that I wanted them to. It was already agitated, this man. But there's a huge clot. So imagine trying to explore this wound and pull off a huge clot.
Airway's still okay though.
Airway's fine.
Yeah.
Anyway, he was fine. Lesson: throw out angle grinders.
Yes, throw them out. Don't use them. Don't worry about the rust. It's okay. Right. So your neck's more important.
And then,
your life's more important.
And then think about how you prepare for penetrating neck injury. Think about the eventuality, so the airway compromise and the circulatory problems.
Think about the assessment. Bearing in mind the zones are not so important. They're going to get a CT angio anyway if it's gone to the platysma. But document all the signs and think about the signs and do a proper and thorough assessment. And don't underestimate neck injury, because you can get caught out very easily. Even the smallest puncture wound, someone can die from.
And disposition's entirely important, so it's either theatre or to CT and then to theatre, unless it's a minor injury, of course. And then just recapping on those skills of graded assertiveness. So you're really explaining why you're concerned, what the options are for escalating medical care, really circling back and demanding a elevation of care, and then I can't remember the last one.
Well, my tip, and the last one, you've done it, but my tip with this is get the person who can do the operation,
ultimate decision maker,
to come and put pressure on the wound.
Why is that? Because then they can't leave.
Because then they can't leave. They're like you. They're now stuck, and they realise, oh, well, my day is over unless I can operate on this person. So get that registrar, get them involved, get the junior registrar, say, can you just put pressure on the wound for a while? And maybe I'll call your friend, because then they'll understand that this is not a trivial wound that can wait for 2 hours in emergency. This needs to go now. Because the only way we're stopping this is by direct pressure. And now it's me. And I can do it because I can operate, from the surgeon. So that's my tip. Get them to put the pressure on the wound.
That's a good tip. Patient did well.
And
I really enjoyed it.
Lucky times.
Yeah.
All right. Well, thanks. That's a great one. Okay. See you next time.
Take away